Staggeringly, between 10 and 20% of all cancer patients are misdiagnosed every year due to improper immunohistochemistry staining. When a slide fails, the instinctual reaction in the lab is almost always to blame the chemistry. We assume the reagents are bad. This chart shows the actual origins of IHC errors, and the chemistry is rarely the culprit. The analytical phase, which includes your primary antibodies, expired reagents, and detection kits, only accounts for 20 to 30% of all issues. The true liability lies in the pre-analytic phase, responsible for 60 to 70% of slide failures. This pre-analytic phase is entirely comprised of manual, physical processing steps: formalin fixation, paraffin embedding, and initial slide drying. Because these errors are physical, they leave distinct, recognizable morphological footprints on the tissue itself. To troubleshoot effectively, we have to work backward from the failed slide to diagnose the exact mechanical error that compromised the run. We can group these visual artifacts into 3 distinct diagnostic categories for reverse engineering. First, the absence of signal; second, nonspecific noise; and third, mechanical degradation. Immunohistochemistry relies on a fragile mechanical ecosystem. Learning to read the visual evidence left on the tissue is the only way to accurately troubleshoot the system. We begin with the false negative, where a known antigen fails to display on the tissue. The critical first diagnostic step is comparing the patient tissue to the internal control. You will frequently see a paradox. The external control is highly positive, but the internal control is incomplete. Notice the focal drop-offs across the membrane. This signature points to a pre-analytic failure. Tissue sections dried out after heat-induced retrieval, physically killing the reaction. Next is the total negative scenario, where both the patient tissue and the positive control show absolutely nothing. If even the counter stain fails to appear, the failure is entirely physical, not immunologic. The root cause of this total diagnostic void is incomplete deparaffinization. Residual wax acts as an impenetrable physical barrier, completely shielding the tissue from reagents. A secondary form of the false negative is signal masking, where the signal actually exists but is visually overpowered. A normal expected result should show diffuse positive staining that stands out clearly, but here an overly aggressive hematoxylin counterstain is too dark. It artificially suppresses and masks the weak positive signals within the nuclei. A missing signal rarely means a defective antibody. Almost always, a physical barrier blocked the chemistry, or an optical imbalance hid the result. Now we shift to the opposite diagnostic problem: slides overloaded with diffuse, noisy, and nonspecific color. Nonspecific binding originates from 3 distinct root causes. First, biological decay; second, enzymatic activity; and third, mechanical trapping. Biologically, degenerating or necrotic cells, like the chaotic zones in this specimen, inherently and randomly bind to reagents, flooding the slide with noise. Enzymatically, acetoperoxidase activity can drive non-immunological binding evenly across the entire slide. The protocol fix for this is simple: ensure endogenous enzyme activity is properly neutralized with inhibitors before detection. The mechanical cause is entirely structural. Detection substrates become physically trapped underneath the tissue. Look at the irregular, hard borders here. Wrinkles, microscopic air bubbles, or water form physical pockets that grab and hold the substrate, creating a pool instead of the targeted stain. The prevention is mechanical. Utilize positively charged slides to flatten the tissue and force absolute adhesion. If the tissue adhesion is compromised, adding more wash steps will not clear the trapped reagents. When evaluating a noisy slide, look at the morphology of the stain first to determine if the tissue is decaying, reacting, or simply trapping liquid. Our final category decodes structural failures on the slide, mapping artifacts dictated by physical placement and spatial gradients. This SMA specimen demonstrates starkly uneven staining intensity across a single contiguous tissue section. This gradient is diagnosed as inadequate primary formalin fixation. The chemical failed to penetrate the deep core of the tissue block. Because the core is unfixed, it is later subjected to secondary alcohol fixation in the processor. This creates highly disparate antigen preservation across the exact same slide. This physical stress can culminate in catastrophic structural failure, complete tissue detachment, and peel-off. This tearing is the result of a chemical tug-of-war between poor initial fixation and an overly aggressive heat-induced epitope retrieval. Poorly fixed tissue physically cannot withstand the boiling temperatures of standard retrieval protocols. Detachment can also be triggered purely by mechanics. Here, large air bubbles trapped during mounting apply outward physical pressure, tearing the tissue as it processes. To stop detachment, step down the retrieval intensity, extend your slide drying time, and strictly enforce the use of charged slides. Uneven staining and tissue lifting are not random chemical anomalies. They are accurate topological maps of pre-analytic physical stress. We have successfully reverse-engineered 3 major classes of visual artifacts back to their mechanical sources. This flowchart maps these visual errors onto the chronological pipeline. Notice exactly where the masked signals, trapped substrates, and lifted tissues originate. There is a massive concentration of aeronodes at the very beginning of the timeline. This is exactly why 60 to 70% of IHC failures live strictly in the pre-analytic phase. Before you swap out a primary antibody, you must audit your mechanical baseline, verify your formalin penetration times, confirm complete dewaxing, and check your slide charging protocols. Treating IHC solely as a biochemical assay guarantees a high failure rate. True precision requires recognizing that the physical integrity of the slide ultimately dictates the diagnostic truth of the chemistry.